Now, as far as our immunity concept exemplar, we are going to cover pulmonary tuberculosis. This is a highly communicable disorder which is caused by the mycobacterium tuberculosis. It is transmitted via aerosolization or airborne. Most common bacterial infection worldwide. It is secondary to TB, and it has an increased incidence secondary to HIV infection. And immunity, so the body's physiological defense mechanism that protect against illness and disease. So those are some concepts you want to focus on. Now, as far as pulmonary tuberculosis pathophysiology, so infected respiratory droplets are essentially inhaled by the uninfected patient, caused by active TB coughs, or someone who is laughing, someone is sneezing, if someone is actually whistling or sings. Most people infected with bacillus, there are most people infected with bacillus than who actually acquire active TB. So in other words, most people will have the bacillus organism, but they won't actually have the active disease. And of course, this is due to the normal protective immunity system that we have, which prevents full development of TB, again, for the healthy patient. So of course, this is when patients test positive, but when you do a chest x-ray, they're not showing any active disease. It's because our immune system is fighting this organism very well. Now, once bacillus multiplies freely, when it reaches sites such as the bronchi or the alveolar, there is an exudative, as far as pus, response occurs. And this leads to a pneumonitis. And of course, this results in development of acquired immunity to TB. Now you're beginning to build up a kind of immunity, acquired immunity. And it is at this time, at this point, that growth of the bacilli is controlled. Again, our immune system is working well. However, small amounts of patients, they will go on to develop active TB. Now, the cell-mediated immunity against TB develops between 2 to 10 weeks after infection and can be seen by a positive reaction to a TB test. I want you to read about the granulomatous inflammation and caseation necrosis on page 605. Just skim that information. It discusses how TB is actually formed. Read also about the area of caseation and how it undergoes resorption, degeneration, and fibrosis on page 605. Other body areas can be infected by TB organism, so it is not just the lungs, by the way. The initial infection period is seen in the middle and the lower lobe of the lung. Sometimes patients can be without signs and symptoms for years, for decades, and so this is referred to as latent TB. Now, a patient infected is contagious once signs and symptoms of the disease occur. Secondary TB occurs as a recurrence of a previous infected person when their immunity is weak. This is often seen in older adults or patients with chronic disease, or also such as HIV being one of those chronic diseases. And the upper lobes are common sites for recurrence of this condition. Want you to read page 606 for the following. On this page, you will read about the etiology section, read the incidence and prevalence of disease section, especially those at greatest risk, such as older, homeless adults, people of lower socioeconomic groups, etc. So there's some additional information there regarding incidence and prevalence. Also read the section on health promotion and maintenance, such as managing risk factors at the societal and personal and societal level. All right, so read that as well. So as far as our interprofessional collaborative care, and also namely physical assessment, most patients aren't aware of the disease TB until it's in its advanced stage. TB does have a slow onset. We look for signs and symptoms as listed above due to, we'll clue you in to an active disease, and we'll go over some of that information as well. As far as history is concerned, you want to ask the patient about their country of origin, and or if they travel to foreign countries. This information is very important. Want you also to read the rest of the information on history taking information like history of previous TB test results, etc. So there's some additional information I want you to read. Ask about foreign patients who received the BCG vaccination. Those who receive this will have a positive skin test for at least 10 years. But you still want to assess for TB with the chest X-ray or the TB Gold test. All right, and also read about the psychosocial assessment data on page 607. Now, as far as some of the symptoms that you might see in these patients, we're looking for progressive fatigue, lethargy, nausea, anorexia, and weight loss. We're looking at irregular menses for women, young women. Also, low-grade fever, chills, and night sweats. We're also looking at these patients who might have a cough, mucopurulent sputum. So that's mucus and pus mixed together in the sputum. There's also blood streaks known as hemoptysis. And also we might auscultate some abnormal breath sounds in these patients as well. Now, there are certain tests that we want to employ to determine if these patients are indeed infected. The NAA test is the most accurate and rapid test. Also, sputum culture confirms a diagnosis of TB. We use the tuberculin Mantox test. So the PPD essentially given intradermally in the forearm, and the end duration has to be 10 millimeters or greater in diameter to have a positive exposure, just exposure. And also as far as blood analysis, there is a quantiferon TB Gold blood test that can be done. There's also a T-spot TB, and there is a Gen Expert Omni, and this is available, or was available in 2016 for the point of care testing, in other words, in a doctor's office. Now, the NATT test is the most accurate and rapid test for TB. And basically, there's analysis of respiratory secretions. It takes about 2 hours for results. Sputum culture, we talked about that, confirming the diagnosis. The quantiferon TB Gold test blood, and also the T-spot TB. Both tests show how the immune system responds to TB bacterium. And we talked about the TB or the Mantox test is most commonly used reliable screening test for TB, and it must be read in 48 to 72 hours. And you all should know that. And of course, it has to be an area of induration or swelling, in other words, and greater than, as I mentioned, 10 millimeters in diameter to indicate exposure. It just can't be redness, in other words. Now, those with decreased immunity are considered positive if the induration is at least 5 millimeters. So it doesn't have to be 10 millimeters, as you would see in a more healthy person. For those with their immune system is impacted for whatever reason, theirs can be much smaller and it still be considered positive. Now, a positive reaction indicates exposure to TB or the presence of inactive or dormant disease. It does not indicate that a patient has an active disease. Further testing is required for that. Now, a negative test or reduced reaction does not mean the elderly or those with reduced immunity is not infected or had some kind of exposure. Remember, they can't mount an attack against this organism. So there's a term that I want you to know is called NRG. That's A as an apple, N-E-R-G-Y. So I want you to look up that term. Screening is important for direct care providers who work with patients at risk, immigrants, foreign-born folks. So you want to take precautions with these patients. A chest X-ray is done on a positive TB skin reaction, and it can show a healed or active disease. That caseation term I talked about and inflammation are seen on an X-ray if the disease is active. Now, if HIV infected, if the patient is HIV infected, an X-ray may be normal, or it may show infiltrate or lymph node enlargement for your HIV patients. So again, just take a look at this example, a positive tuberculin test with an induration. So just take a look at this as an example. So as far as our analysis, interpreting TB section, there's you want to read these priority collaborative problems for patients with TB and what they are due to, such as fatigue, due to lengthy illness, poor gas exchange, and increased energy demands. So of course you have your potential for airway obstruction. You have potential for development of drug-resistant disease and spread of infection. You also have anxiety. See interventions about anxiety on page 609 to 610, and also read page 610 regarding nutrition for these patients. And also there is weight loss and fatigue. That is a possibility with these patients as well. So as far as our implementation of the implementation phase of the nursing process, I should say, we want to promote airway clearance. We also want to decrease drug resistance and infection spread. So therefore, a combination of drug therapy with strict adherence is necessary. These are some of the drugs that I listed here for you. Now, a negative sputum culture means that the patient is no longer infected or infectious. Again, we want to manage anxiety, improve their nutrition, and also manage their fatigue. As far as potential for airway obstruction, we want to encourage these patients to drink plenty of fluids, maintain Maintain a patent airway is similar to what is done for patients with pneumonia and COPD, so take a look at that. We also want to encourage deep breathing, coughing, and also using an incentive spirometer or IS device. As far as potential for development of drug-resistant disease and spread of infection, again, there's a combination drug treatment, which is the most effective treatment of TB, and it decreases transmission. It also destroys the organism faster, the multi-drug technique method. It destroys organisms faster. It reduces emergence of the drug-resistant organisms. This is why they must strictly adhere to this drug treatment. So the combination drug treatment approach also is done as they are more sensitive. This organism sensitive to, or the drug is more sensitive to certain organisms. So we want to encourage these patients to continue treatment until the disease is under control. The first line therapy that is used is INH and rifampin, and also pyrazinamide and ethambutol for the first 8 weeks. And this is known as, or AKA, the initial phase of treatment. And so take a look at page 608, chart 31-1 for first line drug treatment for TB. The continuation phase lasts for another 18 weeks with INH and also rifampin. So the drug therapy duration is pretty long, which makes it very difficult to treat, especially for some of these patients who you don't know where they are sometimes. So again, you want to teach these patients to adhere to the drug regimen and infection control measures, of course. There is a drug called quinolin fumarate, and it is used to treat drug-resistant organisms, but it is life-threatening. So you'll probably not see physicians ordering a drug such as that. Adherence to drugs can be very difficult, especially as it takes a long period of time, as I mentioned, to treat. So nurses must use several tools to enhance compliance. Non-adherence to the drug therapy does lead to drug-resistant infection. Also read on page 609 about multi-resistant TB issues and drugs. Patients in the hospital, they are placed on airborne precautions in a well-ventilated room. The health care staff, family members, or whoever's visiting the patient, good hand washing before and after the patient interaction is vital. The TB mostly is treated actually in the community or the home. So those who are exposed should be tested for TB as well. If the patient coughs or sneezes, you want them to do so in a tissue or place the tissue in a plastic bag while they are out and about to decrease transmission, and also to wear a mask until the drugs are able to suppress the infection is important as well. These patients are instructed that a specimen is needed at least every 2 to 4 weeks once the treatment begins, and until the results of 3 consecutive sputum cultures are negative. So this teaching is certainly vital. When the patient is not contagious, they can return to their former activities. These patients should avoid inhalation irritants to minimize more damage to the lungs. Now, drugs that cause nausea should be taken at night if the prescription is once a day. And if not contraindicated, they should take it with food, and that will increase compliance as well. For the best healing, instruct these patients to eat a diet with high quality proteins, iron, vitamins A, B, and C, and E, and lots of fresh produce. These patients should avoid alcohol due to their potential to cause liver damage, and many anti-tuberculin medications can also damage the liver too, so you have that double impact. Alcohol is also an empty source of calories and can lead to malnutrition in patients who consume alcohol. Plus, those who consume lots of alcohol will not be hungry due to the increased calories that are being provided by the alcohol. Patients who consume alcohol have also less phosphorus, which is an element that is needed for cellular energy compound, or ATP. And of course, this results in less energy, right? And fatigue. Improved nutrition can lead to reduced fatigue. So again, you certainly want to teach them about an appropriate diet. We want to encourage TB patients to resume activity slow and also include rest periods. And also taking drug therapy as prescribed will also improve energy levels as well. Now, as far as care coordination and transition management, we'd like you to read page 610 for the following: home care management, self-management education, and also health care resources. Now, as far as home care management, discharge from the hospital may be delayed if the patient is high risk for non-adherence, and actually you can get a court order for this if need be. You want to collaborate with social services and care manager to assist with care needs post-hospitalization. As far as self-management education, we want to teach the importance of drug adherence and side effects, and ways to reduce side effects, such as taking your medications at nighttime if that is not contraindicated. We want to teach these patients that they no longer are contagious after 2 to 3 consecutive weeks of treatment, but must still continue with treatment as ordered. So there's an important note here. There's a acronym called DOT, or as known as directly observed therapy. This is done as some patients' situation involve this method of drug adherence of treatment and results in treatment success. So they have to be directly observed by a healthcare provider, making sure they take their drugs. Again, this can be court ordered as well. There are fewer relapses and less drug resistance with this method as well. And so a key to prevention is notify all of those in contact with the patient so they can be tested and treated as well. As far as healthcare resources, we want to again teach adherence to follow-up care for 1 year after active treatment. And we want to also refer to other resources like Alcoholics Anonymous, ALA, etc. So make sure you're looking at your resources. Consult with your social worker who have a wealth of knowledge about these resources. And as far as the evaluation and reflecting section, read page 610 for TB when you have an opportunity.